Good morning. Welcome all. My name is Isaac Kohane. I'm a professor here at Harvard Medical School, and I chair the Department of Biomedical Informatics. This is the second annual conference that we've run on precision medicine from a patient-driven perspective. And as I was thinking about my opening comments today, I thought to reveal some of my early motivations, which I realize have been with me for almost 30 years. And I'm about to tell you this, but I actually don't want you to tweet it out. But everything else I want you to tweet out. So here are our hashtags: Rogue Therapeutics, hashtag Rogue Therapeutics, and hashtag PM Precision Medicine 16 HMS, Harvard Medical School. But I'm not sure this is not particularly privileged information, but as you'll see from the story, I'm not so sure that I want it tweeted out. So almost 30 years ago in July, just a few days ago, a few days to come, I was about to start, as I saw it, my first day as a paid doctor. I was MD, PhD. I was starting as an intern at Children's Hospital. And my first day as an intern was July 1st, 1987, at the Brigham Women's Newborn Nursery, where I served as the other interns in that newborn nursery. And so that was my first night there was my first night on call. So I actually do not like, in fact, tend to discount stories that doctors give about their intense training, because I find that they're not very interesting stories, as much as doctors think they're interesting, as compared to what the unfortunate families have to go through. But nonetheless, I'll go into this territory that I tend to disparage sometimes.
Zach, will you move the microphone?
Yeah, there we go. Okay. And so, handed to me almost within 3 hours of my starting as a quote real doctor was a newborn baby, full-term baby, big baby, healthy looking baby, except this baby's one of his lungs had collapsed. And what happens is often you just stick a needle in the chest, you let the lung expand, and everything is fine. But sometimes something happens that's really not good, and this happened in the case of this child, which is we re-expanded the lung, but the baby's lungs decided that because there was not very much oxygen around, that their physiology was very much like what it had been just a few hours before when they were inside mom. So when you're inside mom, you don't want blood going through your lungs, because you're not getting any oxygen from your lungs. You're getting your oxygen through your umbilical cord. And so there's a lot of resistance in the blood vessels in the lung. And so because the baby's lungs, not knowing better, seeing no oxygen, they said, okay, must be in the fetal state. And I'm speaking teleologically, but they were basically just responding in a regulatory way. And the blood vessels in the lungs tightened down, so that no matter how much air and oxygen we passed through the lungs of this child, we couldn't get the oxygen up to a normal level. And although the state of the art, as we think about newborn nurseries, is putting a kid on a ventilator, when you really are in that situation, you're doing two things. One, you're trying to give drugs to re-expand the blood vessels, to make them dilate, using a variety of drugs to make them dilate, and you're handbagging the child to make, hopefully, their lungs work better or get more oxygen. And since I was a doctor, a newly minted doctor, that is, I knew approximately nothing, my job was just to hold the bag and squeeze it all night. And what happened was I watched this child slowly have deteriorating oxygen hour by hour overnight. And and this was 29 years ago, and of course I'll never forget this. I handed to the parents their beautiful newborn full-term child. I handed them their son, back dead, 18 hours later after being born. And you can say, oh yes, Zach, that's a nice story. What does it have to do with this? This is what it has to do with. Here's some things I found out way after the fact as I became older and more ingrained in the system. So it turns out that there is a therapy that was a bit questionable for adults who have lung disease, which is putting them on heart-lung bypass. It's called extracorporeal membrane oxygenation, ECMO. And the trials have been ambiguous around that. At the time, it really had not been tried widely in newborn kids with this persistent pulmonary hypertension of the newborn. But just prior to the death of this child, they had just finished a trial, a multi-year trial at Children's Hospital to use ECMO for these kids. And the trial seemed to show, on average, a good outcome. But this is something very expensive. It requires 2 or 3 people around the baby at all times because you're running the heart-lung machine and all the other things that you require in an ICU. And it was not clear whether or not they were going to do it. Turns out that 3 months later, based on the trial, and I found out after the fact the death of this child, the ECMO became routinely available to kids with this situation. So had this child been born 3 months later, it would be completely normal and alive child. And why do I say that? Because I think that if I had known that and or had been the parent and known that, I would have done whatever it took to get the ECMO team to say, I don't care if you haven't decided whether or not this is standard therapy. My kid's going to die if you don't do this. Let's do it. And it didn't happen. And as I've become older and wiser in medicine, I realized that this happens all the time. And that by not being impatient, by actually saying this is the pace that medicine goes at, we allow millions of people to suffer all the time. We had our keynote speaker, our closing keynote speaker last year, Arlene Sharp, talk about the checkpoint inhibitors in cancer that we've all heard about. And in that spirit, I want us to think about the fact that these checkpoint inhibitors work on average to improve the outcomes, but for certain individuals are complete cures. The cancer goes completely away. Bad actors, such as melanoma and lung cancer, but those individuals are the exception. They're the exception, and yet we are not coming together as a society and saying what, across all the studies, across all the cancers, across all the checkpoint inhibitors, what are the traits in common between the drugs and the patients that make for these exceptional responders? It's not happening. And it's a huge reason for, again, if we all have loved ones who one day or other will face this. And our lack of impatience around this is going to cause us to lose loved ones prematurely.